Again, welcome to everybody to this session of the AgrAbility webinar series. Today we're going to be discussing brain injury, and our presenter today is Dr. Lance Trexler. He's from the Rehabilitation Hospital of Indiana. As you probably know, our original presenter was not able to join us today because of scheduling issues. So Dr. Trexler graciously agreed to step in at the last minute, so we very, very much appreciate his willingness to help us out today. Just a note in terms of our content today, I know we'd originally indicated we'd be talking about some of the technologies and smartphone apps and that type of thing. We are still planning to talk about those. However, we're currently planning a separate webinar to talk about those types of technologies and technologies that could help people with other types of disabilities also. We don't have a date scheduled for that, but we're hoping that will be within the next month or so. And since you've registered for this event, you will be invited to that. So we hope to see you at that event also. Before we get started with the actual presentation, just a few basic webinar instructions, especially for those that have not participated with us before. Hopefully you are hearing me, and if not, please connect with audio through the computer, your computer or phone line. If you're having any issues with that, go to the Communicate menu at the top of your screen on the top left, and you can run a test there. We do have closed captions running. You will have to click on the Media Viewer tab on the lower right corner of your screen if you want to see those. If you don't want to see them, you can simply minimize that screen. In fact, you can minimize or maximize any of those choices on your right. You can also adjust the size of that entire column by dragging between that and the presentation window. If you have questions about the presentation, please either type those into the chat window and make sure you send that to the panelists, please, all panelists. You will have to activate the chat window, possibly. You should have an icon at the top right of your screen to activate or deactivate that. Please don't use the question and answer pod if that is an option for you. Also, if during the question and answer period you would like to ask a question verbally, you should see a raised hand icon next to your name, and you can click on that, and we will do our best to activate your phone or microphone. We do have 4 quick poll questions at the end as we're preparing for the question and answer period, so we'd appreciate your feedback on that. We will also open a final question or pod so you can make comments after we've finished with the question and answer period. We are recording this session, and it will be archived with the rest of our webinars on the agrability.org website under the online training link and the archived link. If you have any technical issues during the presentation, please type those into the chat window. If for some reason you're not able to use the chat window, then you can email us at the agrability@agrability.org email address, and we'll be monitoring that during the session. Excuse me. For those of you who may not be familiar with AgrAbility, we are sponsored by the U.S. Department of Agriculture. We focus on accommodating issues of disability in agriculture, virtually any type of disability in virtually any type of agricultural operation. Every AgrAbility project is a partnership between a land-grant university and at least one nonprofit disability services organization. There is also one national AgrAbility project in addition to the 20 state AgrAbility projects. The National AgrAbility Project is headquartered here at Purdue University, and our partners on that grant include Goodwill of the Finger Lakes, the Arthritis Foundation Heartland Region, University of Illinois at Urbana-Champaign, and Colorado State University. Please feel free to explore the agrability.org website. There are an abundance of different resources there, in addition to the archived webinars that I mentioned previously. So again, we're very thankful that Dr. Lance Trexler has joined us today. He is the Executive Director of the Departments of Rehabilitation and Neuropsychology Department of Rehabilitation, Neuropsychology, and Resource Facilitation at the Rehabilitation Hospital of Indiana. In addition, he is an adjunct clinical professor, assistant professor of physical medicine and rehabilitation at the Indiana University School of Medicine, an adjunct assistant professor of speech and hearing sciences at Indiana University, and an adjunct assistant professor of speech and hearing psychological sciences at Purdue University. American Congress of Rehabilitation Medicine awarded Dr. Trexler the Lifetime Achievement Award in 2011, and that organization also named him a fellow in 2013 and awarded him with the Distinguished Member Award in 2015. Dr. Trexler has published over 35 book chapters and peer-reviewed articles, has given over 120 peer-reviewed and invited presentations at professional conferences throughout North America and Europe. Dr. Trexler is the managing editor of the Cognitive Rehabilitation Manual, translating evidence-based recommendations into practice, published by ACRM in 2012. So without further ado, I will turn things over to Dr. Trexler and pass him the ball so he can begin his presentation.
This is kind of an overview of what we'll cover today, and it's going to be a brief tour. This brain of ours is, of course, complex, and the effects of traumatic brain injury hugely variable in terms of the kind of problems that causes. And we'll touch on those with particular reference to the cognitive and behavioral problems that follow with traumatic brain injury. There are many others, but even covering this scope in a little over an hour is a huge topic that we're going to have a very condensed overview of. So let's start off with this. This is why evolution provided us a face and a skull, because this is what your brain looks like, and so of course looking at faces is much more pleasant, but nonetheless this is the basis of our identity, and how successfully we adapt or don't adapt on a daily basis. I've got to start off with this quote from Hippocrates from the 4th century because it illustrates a number of points. Number one, how old knowledge is about our brain, but secondly, about how wrong Hallmark cards really is about our heart. But anyway, it reads, "Men ought to know that from nothing else but the brain come joys, delights, laughter and sports, and sorrows, griefs, despondency, and lamentations. And by this, in a special manner, we acquire wisdom and knowledge, and see and hear and know what are foul and what are fair, what are bad and what are good, what are sweet and what are unsavory. And by the same organ we become mad and delirious, and fears and terrors assail us. All these things we endure from the brain when it is not healthy. In these ways I am of the opinion that the brain exercises the greatest power in man." So damage to this thing, of course, then sets the stage for a lot of different difficulties, but also from the perspective of a survivor or a victim of injury, as I've been told thousands of times, it's a very scary injury. It's different than breaking your leg. There is the risk of this injury compromising your sense of who it is that you are at a very fundamental level. So anyway, when we talk about the neuropathology, there are two major classifications. One is a closed head injury versus an open head injury. As the name would imply, closed head injury is when the skull remains intact. And this usually happens, for example, in motor vehicle accidents, or someone is ejected from the vehicle, sometimes falls. However, people that fall often have skull fractures, so that would technically be classified as an open head injury. But then, of course, unfortunate injuries like gunshot wounds exemplify an open head injury where the bullet penetrates the skull. Clinically, it's a very important distinction because in the case of a closed head injury, the damage to brain tends to be much more diffuse throughout the entire brain. And as you might expect with an open head injury, the damage tends to be more specific to the area where the actual penetration occurred. We're going to talk very briefly about three different neuropathological mechanisms of injury. One that includes diffuse axonal injury, which is the primary mechanism of injury. The second are the bruises and contusions to brain that can occur in trauma. And third, hematomas and hemorrhages. There are more, but we don't have time to get into them all, and these are the major mechanisms of injury to brain. Diffuse axonal injury, as the name implies, can occur scattered throughout brain, particularly in what's called the white matter of the brain. And over here we see on these images, this is a CT scan showing a recently injured brain. And in this case, you see these little white dots, and these are scattered throughout brain. And represent diffuse axonal injury. And as we'll see in a minute, these are where areas of long axons in the cells themselves have been torn. Now, the truth is that the majority of diffuse axonal injury can't be seen on either MRI or CT because these are microscopic injuries. Here we have now an example of bruises that are much more obvious. These are areas of cortical contusion. So in this case, it looks like the person probably fell and hit the side of their head because the bruises here are located on the side. This is in the frontal region. That's in the parietal region. In the right hemisphere, the way images are set up is that it's on the opposite side. So this is actually the right hemisphere, and this is the left hemisphere of the brain. So this person has got some pretty nasty bruising in brain, as exemplified by those dark regions there. So this is a schematic showing a normal neuron in the brain. This is the cell body, and this is the axon. These are what's called the axon terminals. So these cells talk by way of connectivity between the dendrites of a cell and then the axon terminal. So a message comes from one cell to this cell and this cell to the next cell, and so that's how the brain communicates. This axon is sometimes short, sometimes it's long, but in white matter, they tend to be very long, and sometimes up to inches long, which is really remarkable. This part of the axon communicates information that the cell receives from these cells that precede it, and the axon carries that signal or that information, if you will, down through the axon to the axon terminals, where then that information goes to the next cell. So it's like a telephone wire connecting major sites of communication. When trauma occurs, force fields are flying through the brain, sometimes at very high velocities, and these tiny microscopic axons can get torn or what is called sheared. Through rotational forces or stretching. Again, if you have an axon that's several inches long and that force is traveling through your brain, stretching your brain in a particular direction, these bundles become very vulnerable. And so there is not only a chemical abnormality that arises in terms of this cell's ability to manage the transmission of information, but at a certain point there's a certain anatomical deterioration also, a structural deterioration of the cell that may lead to actual death of the cell. In this case, with the shearing of the axon, what we may see is that the cell is able to function, but its efficiency is slowed, or there may be actual cell death, depending on the severity of the injury to that cell. So this is another schematic. This is the axon itself, and it's been distorted or stretched by virtue of the trauma. And you can see inside of the axon what's happening is that some of the organelles and some of the chemicals that are being transported from the cell body down to the axon terminals are being obstructed from their normal flow. If it gets bad enough, then you see these swelling, the swelling occur in the axon where there's actual complete stoppage of the chemicals and the organelles in flowing down the axon. So this is a serious situation, and in some cases, then that actual axon breaks off. The two on the bottom figure there, those two areas of swelling may actually break apart. So that leads then to what's called a retraction ball, which is what this image is of. So now the cell body has no real axon, and this cell's ability to function stops, and it will die. This is a microscopy or a microscopic study of brain tissue. And if you see on this image, there are some little curved arrows that are pointing towards normal cells and cell bodies. And then you'll also see some arrows pointing to big dark areas in this image. The big dark areas with the arrows, the straight arrows pointing at them, are damaged, swollen axons and cells that are dead by virtue of trauma, as opposed to the little cells that are indicated at the sort of curved arrows. So you can see how much bigger they have become as a consequence of the swelling and then ultimately their death. So they're microscopic injuries. Only 6 to 7% of patients that have traumatic brain injury have, at least with mild traumatic brain injury, have abnormal CT or MRI scans, which is very puzzling to many healthcare professionals, and it's very puzzling to the patients and their families because they know that their brain doesn't function the same. They're having difficulties cognitively, or their behavior has changed, or they're having dizziness, or they're having visual difficulties, and yet the doctor does a CT scan or MRI scan and it comes back normal. And so on one hand, you would think that's a relief, but on the other hand, it's troubling to them because it doesn't explain or help them understand the difficulties or symptoms they're experiencing because their injury can't be seen in that respect. So what happens in these microscopic injuries to the axons is that they actually evolve over 12 to 24 hours, at least in cats. Most humans aren't willing to have biopsies done of their brain after they get a concussion or a head injury, understandably. So our knowledge comes from studying cat brains. But these axonal injuries and the deterioration that occurs in cat goes on for 12 to 24 days, meaning that the symptoms actually get worse. And then there's a phenomena called Wallerian degeneration, which means that if one cell dies, the other cells that were used to communicating with it, they may also retract. So it's kind of like the use it or lose it phenomena. And so that whole network may be compromised if there is a loss of cells, particularly when there's a larger set of cells that die in that area. Now, the good news is that there is a regenerative activity. That means that when a nerve cell gets injured, it's like any other cell in this respect, and that is, if the cell itself doesn't die, it can grow new branches. It can grow new axon terminals to reestablish connectivity between one cell and another. So that's the cool part, and that's the basis for a lot of recovery, at least in the acute phase after injury. Now, this diffuse axonal injury occurs in some very particular areas, and I'm going to go over this quickly. But in the center of this image of this brain on the right here, you'll see kind of a white area there in the middle that goes from the back to the front. That's the corpus callosum. And that's a major, major highway between the left hemisphere and the right hemisphere, and it's just packed with axons that are going from the right hemisphere to the left hemisphere and the left hemisphere to the right hemisphere. So when trauma occurs, of course, all of those long white axons are getting stretched and pulled. Similarly, down at the very bottom of the brain there is the brainstem that's denoted by where you see pons. There's kind of a pink area, and then right above that there's the midbrain. These areas are also comprised of white matter, and so not only are these axons long, and they're going from up and down in the brain there. These areas, the corpus callosum and the midbrain and the brainstem, have a higher density, a higher tissue density compared to the top of the brain there, or the cortex, and so those densities pull apart from each other when the trauma occurs. So diffuse axonal injury occurs really in these areas in the white matter that we're looking at here, including the upper brainstem, which is where it says pons and midbrain, and then this corpus callosum, this large structure in the middle, as well as some other areas throughout the brain. I mentioned earlier that subdural hematoma happens sometimes. So a subdural hematoma is a collection of blood. So not only do brain cells get torn in trauma, but so do blood vessels. And so if a blood vessel gets torn, it leaks blood, and a hematoma forms. And so this becomes potentially very scary, because if they get too big, then there's a great deal of pressure on the brain, which can cause death. So this is why they do CT scans immediately in the emergency department following trauma, because they want to make sure that there's not a subdural that's life-threatening. If there is a subdural, then they need to get in there and do surgery and drain that blood out of there, either through what's called burr holes or by doing a craniotomy. I've got a picture of a subdural here in a minute. This is one on imaging here. This on the right-hand side, the subdural happens to be that yellow area to the right. That's all blood underneath the skull that's pressing on the brain. So in this case, there's then a focal or very specific impairment on the brain tissue itself. Brain does not like blood on it. It's toxic. It screws up the metabolism of the cells, and it's toxic enough that it can cause cell death. So those brain areas or regions there on the right underneath that subdural hematoma are at risk for being impaired by virtue of the trauma. So there's also risk of what's called an intracerebral hematoma. So if the blood vessel that breaks is not on the surface of the brain in the case of the subdural hematoma, but rather is in the interior of the brain, now we get also a very dangerous condition occurring where blood is leaking into the brain tissue itself. And these are drawings as well as what a CT scan looks like. That white area there in the middle image, that CT scan, that's blood. Blood has a high density, and so it appears as a hyperintensity on this image, the white stuff there. So this is obviously really destructive to brain tissue and brain function. If those blood vessels break, of course it's good to try and get that blood evacuated surgically as quickly as possible, but it still inevitably leads to damage. So let's shift here and then talk about incidents real briefly. There are 1.4 million TBIs every year. That's 4,000 a day and 3 a minute. If we go over to the other side here, there are 52,000 deaths every year. 1,365,000 emergency department visits you'll see. And as you well know, not everyone with a head injury always goes to the emergency department. Some people don't seek medical attention in the case of mild traumatic brain injury or concussion. And 275,000 hospitalizations a year. It's a profoundly expensive injury as well. From a prevalence perspective, and I didn't put these data in here, but it's estimated that somewhere between every 8.6 people to every to 10% of people in the United States have a history of a brain injury. So 1 out of 10 to 1 out of or to 8.6% in the population. So it's a really prevalent condition. Fortunately, most of those were mild or concussive injuries, and the recovery was good. If we look at causality, things have changed. The biggest cause used to be motor vehicle accidents. You can see at the bottom now, however, it's estimated to be 17%. It used to be much larger, but it's reduced because of airbags now and restraint systems. Falls are now the biggest reason for traumatic brain injury. And this is also, unfortunately, in part because of people growing older, living longer, and falling more often. 10% are secondary to assault. 16% are struck by or against something. So people or things falling on people's heads. Example, or being struck by something in the head. And then 21% other reasons, which are hugely variable. Now, the good news is as you can see from this image, is 70% of the traumatic brain injuries are mild traumatic brain injuries that recover fine, and that's the majority of us. So you know, there's a brief alteration of consciousness, or maybe something like that, and then within a day or two or 5 or a week, you're fine. In Indiana, we estimate that there's 10,000 every year traumatic brain injuries just based on population and incidence. But now when we look at these two smaller groups, the 15% with the blue area, moderate to severe traumatic brain injury, these people are very vulnerable to have a lifelong disability associated with their injury. And then the sort of the dark red 15%, these are patients that have a mild traumatic brain injury or concussion, but unfortunately have persisting symptoms. So let's talk about severity of brain injury, and we'll get two different perspectives. That is, from the acute perspective and from the post-acute perspective, or the later perspective. Now, the classification of severity in traumatic brain injury is based on 3 different indices in the acute phase. The first is how long is the person unconscious? And so this can be under 20 minutes would be mild. 20 minutes to 36 hours would be classified as moderate, and severe would be greater than 36 hours. Now, in the case of moderate to severe, this is also influenced by the fact that sometimes acutely people get put out chemically. The emergency medical people or the neurosurgeon may sedate the person chemically. So it's not clear whether they're unconscious because of the trauma or because they're out because they've been chemically paralyzed so that they can be better managed. But nonetheless, this is based on the duration of unconsciousness independent of that chemical paralysis. The second way to measure severity is using what's called post-traumatic confusion or post-traumatic amnesia. The puzzling thing about brain injury, traumatic brain injury, is that a person can get hit in the head or be in a car accident and go to the emergency room, be taken to the emergency room, is able to state their name, able to state their date of birth, their social security number, etc., their spouse's phone number, have conversations with the doctor, and leave, and never remember being there. And that's called post-traumatic amnesia. So what happens in trauma is that it biologically arrests the memory processes from putting information into a sort of short-term memory, that is what's going on right now, into long-term memory. And so everyone thinks the patient is fine because they're talking and they're answering questions, and yet they may have no memory of the event or events thereafter for sometimes a day or 2 or 5 days. So it's part of the classification of severity. So mild injuries are less than 24 hours, moderate are 1 to 7 days, and severe injuries have post-traumatic amnesia or confusion for greater than 7 days. Another instrument that was developed to measure severity of brain injury was using the Glasgow Coma Scale. And this is a scale that can be administered by the emergency medical technicians, certainly by nurses and doctors at the hospital trained in this area. The Glasgow Coma Scale score is based on the patient's response, or unresponse, I guess I should say, to verbal stimuli, to physical stimuli, and their ability to respond to commands, for example. So it's 13 to 15 on the Glasgow Coma Scale represents a mild injury, all the way to 8 to 3 for a severe injury, and 3 is really very close to death. That's a person that's just completely unresponsive. And so in a way, what's interesting about the Glasgow Coma Scale is it reflects the depth of coma, which other scales or measures don't tell us. So in terms of the mild head injury, so concussion is a brain injury. The good news is that most of the time it is just a biochemical alteration to the brain. The brain functions based on biochemical functions and the neurons communicating between each other using certain chemicals. And if the stability of that chemical milieu or environment, if you will, is disrupted by a concussion, then it doesn't function right. But by definition, concussion is a mild traumatic brain injury. There's a couple of different grading systems, one developed by the American Academy of Neurology. So it goes from level 1, that's no loss of consciousness, no post-traumatic amnesia, but a period of disorientation or confusion, all the way up to a level 3, which is then the person has a clear loss of consciousness, and they're just out. Level 2 is in between, obviously. Another set of criteria were provided by the American Congress of Rehabilitation Medicine, and the way they defined a traumatic brain injury with reference to concussion also was any loss of any one of these, a loss of consciousness, a loss of memory either before or after the injury, any alteration of mental status, so you're fuzzy, you're just kind of confused for a while, a focal neurologic deficit, and that could be you're having trouble speaking or trouble using your left hand, for example, and then a severity of injury that does not exceed a loss of consciousness of greater than 30 minutes, because that would be a moderate head injury. After 30 minutes, an initial Glasgow Coma Scale score of 13 to 15, or post-traumatic amnesia for greater than 24 hours. These are just ways of classifying whether, in fact, a concussion, a mild head injury occurred. So now let's talk about 6 months later or a year later, because what happens is in the recovery process from traumatic brain injury, it's nonlinear, and to make matters more complicated, while it's unusual, some people deteriorate and decline rather than recover. And some patients with mild traumatic brain injury, 6 months or 12 months later, may actually have moderate levels of disability. And patients with severe brain injury, initially, in a year, may look great. So you say, well, why is the mild traumatic brain injury actually more disabled than the person with the severe brain injury? Well, it gets really complicated and beyond what we can get into today. But in the 6 to 12 month perspective, then we need different assessment strategies, and we need different ways to determine and assess how is this person recovering and where are they at. So in this case now, it's related to brain impairments and things like neuropsychological examination, which is a way to examine things like memory and concentration, frontal lobe functions that are called executive functions. We'll talk about those in a minute. The level of disability is also determined by medical problems or conditions that can be associated with traumatic brain injury, like seizure disorders or paralysis or motor physical impairments associated with the injury, or perhaps blindness or visual impairments or dizziness, balance difficulties, all complicate than what the person looks like in 6 to 9 to 12 or 3 years, months or 3 years later. So at this point, we're interested in the level of disability. How impaired is the first person from a day-to-day functioning perspective? So important issues are like psychosocial adjustment, how independent are they in the home and in the community, and how are they doing from a vocational and recreational perspective. And so it'll be a more clear here in a second as we examine this. When we look at the course of recovery, as I said, the myth about recovery is that people have an injury, and then over the first 6 months or first year, there's a lot of recovery, and then the next 6 months or the next year, there's a little bit more recovery, but then they kind of stabilize out. They maybe are never back to where they were, but the myth is that most of your recovery is in the first 6 to 12 months, and then you're stable. When in fact the reality is there's tremendous variability in how someone is, as I said earlier, in the acute stage does not equal where they are in the post-acute stage. I think this next figure illustrates that. So what we have here is individual patients. Each line on this graph is an individual patient, and it is their score on a particular cognitive test. And so at the very bottom of the image there, you see the number 12. That's their performance on this test at 12 months. And before that, you'll see data that is their performance right after the injury. And then the next dot is their performance 6 months after the injury. And then there's the 12-month dot. That's how they did on this test at 12 months. And then at the far right, you'll see a 60. That's how they did on this test at 60 months post-injury. So each line is an individual. So let's go to the line at the very top on the left, over there where it says 130. So this test, like an IQ test, the average is 100, like IQ test. So an average IQ is 100. So 130 is a really good performance. So here's a guy or a person who has a traumatic brain injury, scores 130 immediately after the injury, and at 6 months later has got a score of approximately 15. So why did this patient get worse in terms of their cognitive functions over the first 6 months? And then you'll see they make a little bit of progress. So at 12 months, they improve, but they're still not as good as they were right after the injury. And then we go all the way to the right, and that person finally, at 60 months post-injury, is where they were immediately after the injury. So why did that person get worse? Now let's take a look at another example. Go down on the scale to the left, go down to 90. So now there's an individual who takes the test right after the injury, gets a 90. 6 months later, takes the same test, gets a 90. He's no better. 12 months later, takes the same test. He's still not any better cognitively. And then he gets worse. And so you follow the line over there to 60 months post-injury, and he's worse off than he was right after his injury. Well, the point is that something else is happening here. Now, this is not diffuse axonal injury, and this is not subdural hematoma, although there may be some patients that are getting worse because they've got a seizure disorder that's out of control, and they can't find the right medication to get it under control. That might be some of this, but in fact, it's the vast majority that are due to other reasons. Now, of course, you'll see individuals in here who recover nicely. So let's go down to on the left again. Let's do the third person down from the 130. So there's one person that's 130 right after injury. There's 115 or approximately. Look at that person. They are 115 right after injury. At 6 months post-injury, they're back. They're up to 130, which is excellent, and they stay that way. So this is, of course, what we'd like to see. But if you look at the different lines, it's not that way all the time. There's a great deal of variability. So why are some people getting worse? Well, the determinants of recovery, as I mentioned, sometimes are medical related. Sometimes people are on the wrong medications, and that can actually make their functioning worse or make them more disabled. Sometimes they got a seizure disorder. Sometimes they've got a disorder of endocrinological functions or hormones. Or sometimes they're developing something called hydrocephalus, which can be lethal if not surgically managed, not identified and surgically managed. But this is the minority of cases. More often than not, what's happening are psychosocial problems and environmental problems. Because of what people are going through, many people get depressed, they get anxiety disorders, sometimes they start developing substance abuse problems, which then only further compromise brain function. So now you've got a brain injury where part of your brain isn't working very well, and then you add on top of that, the healthy brain gets depressed, or the remaining healthy brain gets anxious, or the remaining healthy brain gets toxic because of meth or too much alcohol. Now the healthy brain can't function well, so the severity of the impairments is worse. A lot of times family support is really strong, and people who have a lot of family support recover better. But if patients don't have good family support, they deteriorate. The brain is a use it or lose it. So if you're withdrawn and you're isolated and you're sitting in your bedroom all day and you have no emotional or intellectual support, then your brain literally begins to deteriorate in terms of the functional connectivity of the nerve cells and the nerve networks and their functions. Environment makes a big difference in recovery. So whether you have rehabilitation services, both short and long term, rehab isn't something you do for 3 months and then you're done in a moderate or severe head injury. And to what extent are you participating in society? Not only returning to work, that's a critical issue, but are you involved with friends? Are you playing? Are you doing the same activities recreationally? And this also feeds our brains. It's what keeps us who we are. And disengagement from these social and recreational and vocational activities causes our brains also potentially to decline in their functions rather than recover. And this is why management is such a critical issue. We've recently begun to talk about moderate and severe head injury as a chronic condition that has to be not only rehabilitated but managed, because it's no different than diabetes, for example. You know, you have to take your medications. You have to manage your blood sugar. And a spinal cord injury is a chronic condition. You have to manage it and work with it. And a brain injury, most of the time in moderate and severe injuries, is a chronic condition also. And so monitoring the environment, monitoring your psychosocial functioning, and monitoring you medically all becomes relevant in terms of what the final long-term expression of that injury looks like. So let's drill down now a little bit in taking a more specific look at some of the attention, memory, and what we call executive function impairments that are associated with these injuries, and what are some of the vocational implications. And as Paul mentioned earlier, you'll have a future seminar then in terms of talking about some of the really cool accommodations and applications on iPhones or smartphones that can be used to help compensate or manage some of these conditions. So as a brief overview, there are a few major cognitive domains that are particularly affected by traumatic brain injury. Now, the truth of the matter is you can get almost any kind of impairment following a traumatic brain injury, including visual disturbances, visual blindness. You can get auditory deafness. You can get seizures that look like psychiatric problems, but in fact are seizures. The list goes on, unfortunately, as long as the list of brain functions are. but there are some major categories that are very common across almost all injuries of a traumatic nature. That includes deficits of attention, deficits of memory, and then 2 or 3 categories that fall into this overall, this executive function deficit. And there are two divisions of executive functions. One that has to do with irritability and impulsive behavior, that is regulating your emotions, and then another executive function deficit that is related to your organization of your behavior and your intellectual and cognitive functions. We'll drill down a bit more on that. So now let's talk about attention in a bit more specific way. And each one of these topics, is a seminar potentially in and of itself. So I don't have the time to go into it in great detail, but there are some major divisions, if you will, or types of attention that include arousal and alertness. Obviously, the function of this system, by the way, that starts in the brainstem, is to control our wakefulness. That's why I have my double espresso every morning. So impairments of this system are cognitive fatigue. The impact on work, obviously, is difficulty maintaining activity if I fuzz out. Fortunately, there are some medications that can be used to help with various types of attention problems. And then also there are some very cool and useful fatigue management strategies out there. Another type of attention is called focused attention, where we want to focus on one thing, but we have to inhibit something else. So right now, maybe you're trying to pay attention to this webinar, and you're trying to ignore your back pain, or something that's worrying you about another situation. You want to ignore that right now and focus on something else. And if that system is impaired, then you're distractible. And maybe you're distractible because of your roommate making too much noise, or maybe you're distractible because of something internal going on inside of you, something you're worried about, or something that's distressing. So the impact on work is distractibility, or you're getting off track in a sequence. The way we manage that a lot of times is helping people reduce distractions in the environment. Also setting up to-do lists so that they can stay focused better. Sometimes reminder or alarms are useful. And we use our iPhone clock, so you can use any smartphone clock for that to set off an alarm, and maybe with a certain frequency. Another kind of attention is sustained attention, which is the capacity to maintain attention over a long period of time. So you've all been in situations where you have to maintain attention over a long period of time. You're driving from Nebraska to California. The highway can get really boring and suck every bit of energy out of your brain. So but you've got to maintain attention over a long period of time. Or sometimes after injury, that long period of time is 30 minutes. And so sustaining attention over 30 minutes may be a real challenge. And so this sets up a very strange situation for the patient because they know they should be able to do this. And family or coworkers don't get it either, because the person could be functioning perfectly normally one moment, and the next moment not at all functioning normally, and yet the person looks the same. You can't see the fatigue in their brain, and they can't either. They don't notice it. They don't know it's coming. And so all of a sudden they find themselves fuzzed out and not functioning well, and they can't explain to you why. And so it's very frustrating, and it's difficult for everybody. It means that in terms of work activities, everything we've said before, plus it means that they may be slow to learn, and then they get frustrated and they withdraw, which is understandable. So some possible treatments, including all the above, include taking breaks. That's part of a fatigue management strategy. Certainly taking one step at a time, keeping a list of priorities, tasks are all helpful in managing some of these difficulties. The most complex kind of attention is called divided attention. This is something now in our culture we do a lot of, obviously, and that is multitasking. So you're talking on the telephone and you're responding to emails and you're making a cup of coffee all at the same time. Impairments in this respect always almost lead to irritability because you can't shift and you're messing up things that once were easy or normal. And it's frustrating because you may lose set, we call it lose set, that is understanding you're going about doing a task and you have a strategy to perform that task, and then all of a sudden you forget how to do it or you're not using it. And then you become confused and you say, what am I doing? This was easy at one point, and it's very difficult. So these are some of the disorders of attention and a very quick discussion of impact on work and some management strategies. Memory is the most fascinating set of systems in the brain, and I wish we had much more time. But many, in fact, all of the human brain is involved in memory. And there are some centers that are particularly involved, but it's decidedly a very distributed network, a complex system of centers and networks that serve different kinds of memory. And there's many different types of memory. And we're only going to just talk about a few of them that are particularly related to traumatic brain injury. So declarative memory is one type of memory. It's memory for conscious facts and experiences. So declarative is, you can say it, you can declare your memory for example, what you did for your birthday or what you did for your last vacation, which is an example of episodic memory. So I've got it in yellow there. Episodic memory is memory for events in your life that are tied to a particular episode in time. So your birthday, what you did for your anniversary, your last vacation, whatever. So these are and you're conscious of it, as opposed to other types of memory where you may not be so aware. Another kind of declarative memory is semantic memory, and we're not going to talk so much about that. It can get affected in traumatic brain injury, but it usually doesn't. Semantic memory is memory for factual information. So who is Abraham Lincoln, for example? So many of you are going to be able to say, well, gee, I know who that guy is. But if I ask you, when did you learn who Abraham Lincoln was, it's going to be hard for you to say because you don't remember it as an episode. It's not tied to time. It's tied to meaning, the meaning of that name, Abraham Lincoln, and then all of the things that are associated with that. But episodic memory is particularly affected by traumatic brain injury. Another kind of memory is called procedural memory, or memory how to go about doing things. So for example, how to start a tractor, how to hook up a plow, are procedures. They're a sequence of motor and physical steps and skills that interestingly are stored in different brain regions than declarative memory. And so, unfortunately, most of the time, for things that people know how to do before they get hurt, they retain that memory, again, because it's stored in different brain areas. Now, learning new procedures after the injury is a different matter. That may be difficult for them and it may not. But the vast majority of the time, people retain those procedural skills, which is also very puzzling for them because in that way they seem like they were, or quote, normal, end quote, for them, but at the same time have all these other different kinds of memory problems. And they'll say, well, I remember how to do, X, Y, Z, but I don't remember what I did yesterday. The next kind of memory that's often affected is working memory. Working memory is that elusive memory we all have impairments with sometimes. It's easily disrupted. Working memory is that kind of memory that is You're walking out to the garage to get something or to the barn to get a tool, and by the time you get there, you forget what it was you went to get and why. So working memory is kind of what is online right now. From a computer perspective, it's RAM. What are you managing right now? It's short-term storage. And that's served by the frontal lobes of the brain in particular, as is prospective memory. Prospective memory is remembering according to your intent or plan, or remembering to remember. So today, you remembered that at 2 o'clock you have a webinar, unless you had it set up in your Outlook calendar that reminded you, and you remembered, oh, gee, I need to get ready for this webinar, and I have to dial in, and I have to do whatever. So you remembered to remember because you intended or planned to do that. So that's memory for what you're supposed to do in the future. So these three areas of memory are in the most frequently affected by trauma. Working memory, as we said, is what is online at the moment. If it's impaired, you lose track of your ongoing focus, which again is really frustrating for people when they know they should be able to keep that in mind. They forget what work activity is they're to be doing or what the priority is. The only way to management is to have small pieces of data or information you're dealing with. Management of distractions is really important. When we're returning people to drive, you never let the person play the radio, have a conversation when they're trying to drive, because you don't interfere with their working memory. Same is true for operation of any equipment, and managing that's a really critical issue. Now, working memory, like attention, can also be helped sometimes by pharmacologic agents, different medications. And I wish we could talk about that more, but there are some possibilities in that respect. Episodic memory, we've talked about that being memory for events. So the impairments are forgetting of your own experiences or what you've learned. So you learn one day that this is how you go about performing a certain function at work, or this is how you this is the combination of chemicals you use, or this is it can be any information, and you may remember that you learned it yesterday, and yet you can't remember it. Which is just excruciatingly frustrating. Repetition really helps, but what's important is that it has the consistent strategy. That is, the person repeats it in exactly the same way, so that it's not done 5 different ways. It's done one way consistently. With respect to remembering to remember or prospective memory, as we said, that's forgetting what is intended or planned or future memory. Task guidance systems. A task guidance system is simply how to go about doing something. It can be a very elaborate iPhone app, or it can be a piece of paper with a sequence of steps on it that when you want to do something for that specific task, these are the steps you use. You can use alarms. Memory notebooks are well known in the literature and there's particular ways you can train people to use memory notebooks to help them get around those problems. So now we're going to shift, and I'm going to quickly go through this, the executive functions or the frontal lobes. This is the most fascinating aspect of human neuroanatomy, and the frontal lobes are a huge portion of the human brain. The frontal lobes, if you look at the top figure there of the colored brain, so the frontal lobes, this is a view from the side of the brain, and you see that blue area in the middle. That begins the frontal lobes, and everything to the left. That yellow area that says MA is part of the frontal lobes, and the PC, which is not politically correct, but is prefrontal cortex. And the pink area is especially the area we're going to talk about. The yellow area is part of motor cortex, that is serving how we move and how we plan our movement. But the pink area in the front there is this large area of frontal cortex that is really the command center for overall brain functions. It's the executive. It is what the frontal lobes do is they take all the information that we're getting from the outside world, which is what the back half of the brain is processing. So if I just real briefly, if I go to the top figure again of the colored brain, the little blue area at the very right of that figure in the back of the brain, that's your visual area. So that's where you're analyzing visual data. If you come a bit forward towards the center of our brain, there's another little blue area, and it's kind of hard to see, but there's an A1 in it. That's your auditory area. That's where you process what you hear. And then right above that, you'll see a long blue strip that's called S1, which is where you process what you feel on the other side of your body, in your hand, your leg, your face, and whatever. So the back half is devoted to analyzing what's going on in the world around us. If you go to the bottom figure, there's this whole neat system called the limbic system, and that's deep in our brain. The limbic system is managing what we feel and what our motivation is. So it's driving hunger, it's driving drives, it's driving sexuality, it's driving it's biological things like blood sugar level, for example. Oh, gee, I'm hungry, I need to raise my blood sugar. It's driving our hormonal system through the hypothalamus and the pituitary gland. And it's driving respiration and thermal regulation, but basically the limbic system and memory, because memory is inside of us. It's based on what we've learned, but we store it inside of us. So our feelings and our memory are deep in the brain in this limbic system. The frontal lobes puts it all together. So we got stuff from the outside world coming up from the back half of the brain on the top figure. The frontal lobes have got the stuff coming up from the limbic system. It says, oh, gee, I'm hungry, but gee, I can't go eat. The frontal lobes say, oh, well, you can't go eat because you've got a webinar at 2 o'clock. And so it puts the brakes on the limbic system and says, no, can't do that. We'll do that later. Because my goal or my intent is to do this webinar, or I want to adapt the situation, which is really what the frontal lobes and executive functions are all about, and that is adapting to an ever-changing world around us and to the dynamics of what's happening with us day to day, our feelings, our emotions, our memories, our biological state. The frontal lobes integrate all of that and say, well, the best thing to do based on my memory and based on my learning and based on what I see around me is to do X, Y, and Z. The frontal lobes are also what make changes. So now you're driving to work and your usual route is flooded. So the frontal lobes generate problem-solving strategies to adapt. And they generate these new strategies and test them to see how they're working. They monitor if they're working or not, and they make changes as necessary. So they're hugely important areas of the brain. Unfortunately, they are also very frequently affected by traumatic brain injury. Now, there's some subdivisions as we talked. So over on the left-hand side, you can see that there's an area called the anterior cingulate cortex that is really our intention and initiation. So if I say, oh, I really want to learn, so I want to go to this webinar, that's what I intend to do. That's my goal. That's my drive. And so that's why it's kind of in between the limbic system underneath it, and then in front of it is then this what's called dorsolateral prefrontal cortex. That's the orange area. The orange area is the planning. So I intend to do this webinar. I think I would like to do it, and so then it sends it up to this orange area, and it says, well, okay, then I need to cancel my meeting that I had for 2 o'clock. I need to make sure that I have got this taken care of, that I've got that taken care of, so that I can go do that. It's self-monitoring the system and saying, well, am I reaching the steps that I need to reach to get to that goal? So now I've got a series, to take a different example, I've got a series of errands I want to do today. I'm going to monitor This part of cortex is going to monitor, am I getting them done in a timely fashion? Or, gee, I'm not, I'm running late, I need to modify my strategy. Let's go about this in a different way. So impairments in this area lead to all kinds of organizational problems in day-to-day life. If you go down now to the little green area called the orbital frontal cortex, this is where we regulate our mood and our drive. And so if you go back to the previous slide, it's the brakes, if you will, on this limbic system down at the bottom. So the limbic system says, oh, gee, I'm really hungry. And the orbital frontal cortex says, well, not now, because it's not appropriate to do that right now because you've got this and this to get done. So you're already imagining, I'm sure, what happens to people with injury in this part of the brain. And unfortunately, it's really common for reasons I don't have time to go into. But let's break it down now into two major divisions. One is the dorsolateral convexity, and that's the part back here. Let me go back to the previous slide. So the dorsolateral prefrontal cortex is that orange area up there in the very top of the frontal lobes. So the functions we briefly touched on: initiation, organizing, planning. So what are the impairments? Difficulties developing goals. They look kind of depressed. You think they don't care, but they really do care, but they just don't know how to turn it into initiation. Impaired sequencing and problem solving. They can't find a strategy to solve the problem. They're often unaware that they're having difficulties and then get really frustrated. The results, what comes out of their desire, is discrepant from their intention, which is really frustrating for them. They want to do this task, or this job, but then are just dismayed when for many reasons that doesn't happen. The impact on work is difficulty generating or staying consistent, not following through with stated goals. Again, it looks motivational. It looks like they don't care. It looks like a behavioral problem when it's not. People blame patients with frontal lobe injuries and say they don't care, when in fact it's a neurologic symptom. They have difficulties adjusting to change. They're slow to learn new steps or procedures. As I've said, they get frustrated between the discrepancy between their goal, that is, they want to perform, and actual performance, and difficulties learning from mistakes. On the other hand, we have this orbital frontal cortex, which is this green area down here on the figure on the right, and it frequently gets injured because of the anatomy of the skull in that area. It's regulation of mood and behavior. So the impairments that follow are, unfortunately, people with trauma can be very impulsive, do things without thinking through it. They can be disinhibited and say and do things they really shouldn't. They may swear at inappropriate times. They may be inappropriately sexual at times. They may. All of us have wanted to swear our boss out, and yet said, "I don't think that's a good idea. I think I'll put the brakes on that." They can look like they're indifferent. They may be irritable or jocular. They're joking when they shouldn't be. They can, and in contrast, cognitively, they can generate a strategy to go about solving a problem, and then get distracted away from it. And so they'll be driving to come to work, and they'll see an old friend. Oh, gee, I think I'll stop and talk to the old friend. And now it's all of a sudden it's an hour later. And then they go, oh my gosh, I'm late for work. So they take off and get back to heading to work. And then all of a sudden they hear on the radio that they've got a special at the store. Then they end up there, or the bar. And now all of a sudden the organization of their behavior is compromised. So these folks are distractible on the job because of intrusive thoughts or feelings or external distractions. They're impulsive sometimes with statements or actions. They veer off task. Their performance is inconsistent. They appear indifferent to job errors at the moment, and yet have no understanding of why, and are frustrated and disappointed when they lose a job, and they appear to overreact emotionally. They get misdiagnosed as psychiatric problems all the time, particularly bipolar disorder, and particularly well, and others, but especially that. There's a lot of different vocational strategies. I know I'm running out of time for these executive functions. Basically, there's some external queuing strategies, ways of structuring a to-do list, breaking things into steps. Structure is huge. Having an external structure that's consistent and written strategies and checklists to go about things in a consistent way is hugely important for these folks. Stop and think strategies for regulation of mood. I do want to make you aware of a manual that I was the managing editor for, and another colleague of mine here, Ed Haskins, was the primary author. We were working with the American Congress of Rehabilitation Medicine. This was published in 2013, I think. What we did was we took all of the research that was out there in terms of what is effective in treating these kind of cognitive problems for people with traumatic brain injury, and we condensed it down to this manual for therapists so they could quickly find therapeutic techniques that work for these folks. The American Congress provides a 2-day workshop also 3 or 4 times a year for people who want to learn how to use these therapeutic techniques. The manual is on the website as well. So that's a resource. I guess for those of you who are working with people, I would really urge you to find a network or a village of people that can help you, because it takes a village to work with these folks. People in physical medicine and rehabilitation, there are physicians that can specialize in this area, neuropsychologists like myself. Rehabilitation therapists are often necessary to help with cognitive rehabilitation to address these problems, employment specialists, vocational rehab counselors, and many others. Get a team together to help you because it really is it's a complex matter, and when you have that team, it can be much more successful. So thank you very much for your interest in this topic, and we can do some questions now as you need. Thank you.
Thank you again, Dr. Trexler, for that excellent presentation. Some really good information. Before we start with the questions and answers, I'm going to do our quick poll questions. And if you do have questions, please feel free to enter those into the chat window. I know we do have a couple, at least at this point, so feel free to go ahead and do that, or you can raise your hand and we will do our best to activate your microphone or phone line. So the first question we have asks about your affiliation. If you could let us know which of these categories best fits you. You may be in multiple categories, but please choose the best one. Just a few more seconds on that. Okay. I'll be closing here in just a few seconds. Okay, so you can hopefully see the results there. I'll save those results. And go to our next poll. Our next poll asks about the information that was presented today. And it asks if you felt it was what you were looking for. So let me open that one. Was it valuable and did it meet your expectations? A few more seconds on that poll. And I'll be closing it. Okay, and you can hopefully see the results there. I'll save those. Our next poll asks about the technology today. Could you please let us know if the technology worked for you? If you had any specific problems, please, if you would, let us know in the chat window so we can try to work on those. Also, if you did have multiple people participating at your site, it would be helpful for us to know that also. So if you had more than one person watching, but you're only logged into that one computer, if you could just send us a quick chat, that will help us determine the number of actual participants. So just a few more seconds and I'll close that poll. And we have one final poll question up in just a second. Okay, so I will share those results and save the results. Finally, we ask, based on today's session, would you attend another session in this series? As soon as we're finished here, I'm going to turn things over to Cliff Raz, our IT specialist, who will be coordinating the question and answer period. And then after the question and answer period, we will open a final poll. If you have comments, specific comments you would like to type into that question, we can do that. We're closing this poll in just a second. And sharing the results. Okay, thank you for your participation. We appreciate that. At this point, I'm going to turn things over to Cliff and Dr. Trexler again so that we can answer your questions as best we can.
Thank you, Paul. I'm going to go ahead and share the questions here for everyone to see. We have a series of several questions here, the first of which, why is blood toxic on the brain? And we'll just give it a moment for
now you can hear
Trexler
me.
to
Yeah,
enable
thank you.
his
Good
microphone.
question. Why is the blood toxic? Great question. So so blood has got, amongst a variety of things, a lot of iron in it. And the nerve cells are particularly sensitive to anything that disrupts the chemical stability of that cell. So it's really eloquent and beautiful how these cells function, but they function based on particularly sodium and potassium. And sodium and potassium ions are flying in and out of the cell membrane and communicating down from the cell body to these axon terminals through this exchange of chemicals coming in and out of the membrane. And then that's what tells the next cell to either fire or to not. And so its chemical stability is really very fragile. And so the blood disrupts that chemical stability, and that's the first problem. The second problem is if that blood hangs around a while, then it's so toxic that it actually starts killing brain cells. So now you start to see, the actual brain tissue deteriorate where that blood has been laying on top of it. So if you do have blood on the brain, that's not a good thing. But if you do, you want to get it out of there as quickly as possible. Hope that answers your question. Thank you. So I think Cliff, did we have some other questions? Or? Hello?
Cliff, I'm not sure if you're still there.
Did we maybe lose Cliff? Oh, we may. My colleague here is telling me that we maybe had a connection failure.
Okay. I did see a couple other questions here in the chat. I will go ahead and just read those off. Are you able to hear me?
Paul, and those are your frontal lobes adapting to the changing environment.
I'm glad they're working today.
Yeah, right.
Okay. I did have a little problem on my end with technical stuff, too. One question was about, especially with our audience today, people that deal with heavy equipment, tractors, combines. Do you have any recommendations for trying to evaluate safety for brain injury survivors that might be using those types of equipment?
So I think that's a really cool question. This is why it takes a village. So I would strongly recommend an occupational therapist be involved in that process, one who has got some brain injury experience. I'm biased that my wife is a brain injury occupational therapist, and they can be really useful in helping in that respect. It's really important to do an on-site evaluation to see how the individual actually performs on the tractor or on the combine, because what happens in your office does not predict well how people function in the real world. Vocational rehab, state vocational rehabilitation people typically know exactly who the right people are for that kind of thing. And so if you don't know, I would get a hold of your state vocational rehabilitation agency, and they can typically help you.
Okay, thank you. Let's take another look here. Questions. Are support groups helpful for brain injury survivors?
You guys are great. So brain injury support groups are a critical element of the recovery process. And I am going to make a plug for Indiana for just a second, if you don't mind, Paul. Indiana has got now the best vocational outcomes in the country for people with brain injury because of a new program that we have developed with them together called Resource Facilitation. And it's an evidence-based intervention where we're working closely with a variety of environmental resources, but the brain injury support groups is a critical part of that. And brain injury support groups help number one, educate people and their families. They provide emotional support. They provide intellectual support, as long as they're not complain sessions. And so this is one important issue. So if the support group is people sitting around and complaining for the next 3 days, then that's not helpful. But well-trained support group leaders make a huge difference for people recovering. We provide support group leader training as part of our research and training, our brain injury research and training center, and because they're so valuable in the recovery process. So yes, I would strongly endorse support group, brain injury support groups. Like everybody, they need the right training, but they can make a significant difference in recovery. Yeah.
Okay, a question from Patricia. What is the prognosis of a person with brain injury longer than 5 years?
So that's not unusual at all, Patricia. And so many times it's a chronic condition. That doesn't mean that people can't function better. They decidedly can. And you can reduce disability with the right intervention, and people can become more disabled in the absence of the appropriate treatment or intervention. They can wax and they can wane. If they get depressed, they might get worse. If they start using meth, they might get worse. They might get better if they've got a good psychotherapist. They might get better if they get back to work. They might function worse if they're on the wrong medication, and they might function better if they're on the right medication. So this is why it's moderate to severe traumatic brain injury is disease management, and it should be managed by a team of people who know that particular disorder.
I think we have one final question. For rural audiences, is telemedicine effective for brain injury survivors?
So that's a beautiful question, and the short answer is we don't have research to tell us the answer to that. But I see no reason why that would not be a tremendous idea. Please get with your state, and there's at the moment everyone has got a different regulation for telemedicine, from federal to state agencies, and so we're trying to get a telehealth system set up to provide care to rural people with brain injury, and it's extremely complicated because of the different federal and state regulations and different perspectives on it. But I think it's an extremely good idea, and we need to commit to doing that.
Okay, thank you again, Dr. Trexler, and for everybody that participated again. Again, just a great effort in terms of helping us out at the last minute. So our thanks go to you again. And a reminder to those that participated today, we will be hopefully scheduling our next session that deals with some of the technologies in the near future, and we'll be inviting you to that. So with that, we will bid you a good day and hope to see you soon.